Hello everyone, I'm Dr. Prathap MS, currently heading the Department of Conservative Dentistry and Endodontics. And today I'm here to present on the posterior composite restorations, which is the most commonly practiced technique in dentistry nowadays. Gone are those days when we use silver amalgam restorations, because once upon a time those silver amalgam restorations used to be considered as the benchmark restorations. Though it's a time tested and very good material, but then people never preferred any kind of silver restorations in their mouth, and the demand has raised so much of in such a way that the younger generation wants only white or the tooth colored restorations. So posterior composite becomes a pertinent chapter in our day-to-day curriculum as well as teaching activities. So let's find out in detail how a posterior composite restoration has to be done. So coming back to, let me first tell the objectives of this presentation. That is mainly to understand the science of composite restorations in basics, in brief I would tell. Then know what are the steps of posterior composite restorations, and then to understand how to choose, apply, and all bonding system, composite matrices and layering technique, everything in brief shall be explained in this presentation. So let's understand what is dental composite first. So dental composite, according to Philip, we all know that composite can be defined as a compound of two or more distinctly different materials with properties that are superior or intermediate to those of individual constituents. So otherwise, basically, to keep it in simple words, it just comes with a resin matrix in which there are a lot of fillers present, which is dispersed in that, and then to bind between them we use something called coupling agent, which is organosilanes otherwise, which makes the entire thing a complex structure, giving it a very strong, or we can tell as close as, because we always consider amalgam as the benchmark material, we can consider this also now having the similar strength of that of amalgam. So what are those materials basically classified as? That is, they have direct, indirect, that is based on the restorative procedure. Then we have according to the composition. So maybe the filler particle gives its strength, mainly contributes towards its strength. So let us classify it as macrofilled, microfilled, hybrid, modern hybrid and nano hybrids. But this modern hybrids and nano composites are the modern ones. Maybe of late, past 5 years, it has reached its maximum. I would say the research activities are maximum happening on this particular area. So we will be only considering those techniques in this presentation which are closely associated with nano composites. Then coming to the clinical applications, we have packable, we have flowable, we have polyacid modified, self-adhesive, osmotic, bulk fill. But these are all based on one's clinical expertise. Like for a beginner, I would say a flowable composite and plus a bulk fill or a hybrid or nano hybrid can serve the entire purpose. As and when they progress in practice and they understand in depth of the variety of cases, indications differ. That is when the different kind of composites come into picture. And again, curing modes, that is chemically activated, light activated, heat cured. But what we are only concerned is about light activated. So let's focus on how next case selection can be done. That is, after understanding these materials, before we go into the clinical aspects, always remember every clinical cases has got different the patient, it differs from patient to patient, and it has got different kind of applications. So one should understand what is the right case. So especially when we talk about composites are considered to be little technique sensitive because it needs 100% isolation during the procedure. So we will have to select the case accordingly, and we'll have to see So many factors are there which might not be part of this discussion because that will take long time. So let's basically understand that with the correct location of caries and the habits, oral habits of the patients, let us choose the right material, different types of composites. So these are all making smart decisions. It all comes through your clinical practice. As and when you get experience, you take smarter decision faster. So let's briefly understand how these stages of caries activities take place. So first one is the incipient caries. Incipient caries are those which we can remineralize, I believe, because those are just to be, in a routine examination, sometimes we find it. Otherwise, there are tools which we can, like imaging systems and, tools like diagnostic tools like Diagnodent, which are nowadays very commonly used to find out initial incipient lesions. Such things are reversible or remineralizable using certain paste. We can use, there are so many remineralization toothpaste available in the market, or we can try with tooth mousse and other systems which is available. Then we can think of, if it goes further, little further, if it is not, if it is advancing, then it can be classified into moderate, and then we can think about resin infiltrations. Resin infiltrations also, we have got many. Now we have got fluoride containing pit and fissure sealants and all, which can be tried, so that it can be. And also we have resin modified GIC, which are light curable, so those things can be tried in the initial stages. But then once it goes to advanced stages, that is when the problem comes. That is when we really go into proper composite restorations, so called posterior restorations. Then the cavity preparations becomes deeper, and there is another case wherein it might go to severe, that is deeper cases, wherein we will have to understand how to give line, because modern liners are very good. We have gone much ahead in liners also. That is wherein before we used to use calcium hydroxide light cure based calcium hydroxide liners and glass enamel liners. Now we have gone to tricalcium silicate based. So calcium silicate liners are better now, and they are known to regenerate. They are even used as in cases of vital pulp therapy. So that is altogether a different topic to discuss. So let's go to the steps of this. So first, isolation. As I said before, here the biggest challenge for composite restoration is isolate. Isolation is a must, because it is totally depending on this, the success of restoration happens. So first you should learn thorough isolation, so which is not part of the presentation. I will only briefly touch and go. So otherwise, clinical scenarios wherein you cannot isolate properly, all that we can try and do is, we have got mouth probes and other devices, suction devices, which can keep your tongue and other cheeks retracted. And there are other cheek retracting appliances like Umbrella, which is a very good one, which is used by Ultradent company, which has got all cheek and lip retraction simultaneously happening with tongue depression, which can also keep it isolated. But remember, cotton rolls should be kept, not cotton, the normal cotton made hand rolled, because that might have cotton fibrils which can attach to the bonding systems, or it can interfere with the bonding. So ideally, a rubber dam would be the best isolation technique. So while isolating with rubber dam, these are things that we have to take care. That is, we should use the Tucker technique, wherein we have to make sure that the proximal aspects everywhere it is tucked in, so that it will be clearly visible, and preferably a background where we can see things well. So the background here, you can see in the picture how nicely we can, the contrast is seen so well that we can nicely see the margins and very well adapt the materials at the margin. That is very, very important. Then coming to the caries classification based on the depth, that is, just to brief you how it goes, is from the incipient lesions to the deeper lesions. We have got from enamel, dentine. So why we should know this is because as per the depth is our choice of bonding agents, as well as If at all we have to place some kind of liner underneath, we will have to decide at this particular point, that is based on the depth of the lesion. That is why we should briefly understand this. So enamel E1 E2 tells it is in this depth, and D1 D2 D3 gives you the different depth into the dentine, because as and when the depth increases, you are closer to the pulp, and you also know that the tubules is going to be wider. So we will have to be very careful, because we are going to use chemicals on top of it, which is bonding, and all these resin materials definitely are chemical agents. So remember, we should block all these things penetrating into the pulpal space, so that the tooth will be not lose its vitality. So also understand now, the depth of the caries is based on different histopathologically structures also. Histopathologically also there is another difference. So as and when we go deeper, let us see this. That is, when we first, it will be soft, that is the texture, or in clinically how to identify. For experienced clinicians, it is easy to firmly just, when they scrape it, or when they use spoon excavator to excavate it, they come to know how deep it is, or how firm the dentine beneath is, so that what is infected, what is affected dentine and all. But for a beginner, it might not be the same. So what we can do, let's briefly see how we can find out this. That is, soft dentine, initially we can scrape it off. Then once we start feeling firm, then that is when we can use different burrs, and in slow speed especially, because here we should use only medium speed, not high speed. So carefully excavate this dentine, and then reach till that demineralized zone wherein we need not, otherwise we call it not the infected but the affected dentine. We can stop at the affected dentine, wherein we have to now decide whether we have to remove it or keep it. So that depends on the kind of lesion, the clinical scenario, like chronic cases, and the age of the patient. There are so many other factors, so let's not go into that. But that in general, what we have to see is all these zones we should understand. First zone is the necrotic, then the contaminated, that is soft ones are necrotic and contaminated. Then the dentine slower is little harder ones. They will be demineralized zone is that little leathery consistency. Then comes the translucent zone, again leathery but firm. Sound dentine is very hard. Reparative dentine is again hard. These are things which we should not touch. When it is hard, it is better to leave it, because that means that is the body has created a layer of dentine which is hard enough to protect the pulp underneath. So we need not touch that area. That is when we have to take a call. After this, we can go for some kind of lining which will give soothing effect to the dentine. Here we should not give anything harsh, so that it will deteriorate this situation and cause non-vitality. So if you are confused, that is clinically you cannot figure out what exactly, we have got something called caries detecting dice. You can apply that, and I will go into detail of it, how to identify it properly. Or else we have got a smarter system which is called smart burrs nowadays. They are all polymer burrs, and because they have got the compressive strength or of this burr is much, it's here. If at all you apply too much force also, it doesn't allow the normal dentine. That is, when there is a hard dentine, it doesn't cut that. So it matches with that of the soft dentine, and it stops cutting there. After that, it doesn't cut. So we all know that when we use a harder material, or that is when we can cut. That's why we use diamond point abrasives to take out tooth structures. So here, when the polymer material is used, it is believed that it takes out only what is required. So remember to have sharper instruments. This is something that clinically everybody should always maintain, is sharp spoon excavators. In such scenarios, that is the only instrument that can help you scrape the correct dentine and make sure that all the infected dentine is completely removed. Otherwise, when you use a blunt instrument, there are very high chances that you might leave little bit of such dentine. So just to give you a gist of this the dye is used. So this is how the dye is used, and see, those part which is stained too dark has to be removed, but whereas when it is lighter you can preserve. So that you should take the call on the chair according to the cases that you handle. Certain cases, when it is chronic cases, sclerotic dentine is beneath, you might get it little discolored, but then again if it is firm you need not remove that part. That should be that will definitely be based on the clinical expertise. Now, to give you another picture of how to identify this is with the right diagnostic aids. If you have a bite-wing radiograph and trans-illumination, other facilities if you have, initially itself you will get a picture of how much is that going to be. So coming to how conventional class 2 cavity preparations were, we'll just have a look at that and then go into the modern cavity preparations. So conventional cavity preparations, as we all know, we had a occlusal dovetail, then we had to give that proximal extension, then we had to give retention grooves, and slot preparations were another option. Then we had tunnel preparations coming in telling that it's a minimally invasive. But then now the scenario is different because bonding has given us, newer techniques of bonding has allowed us to make minimal preparations. So evolution has happened now. So from old to new, now there is, remember that we just have to only remove caries and make sure that you get peripheral seal, that is the bonding of the material everywhere, preferably in the enamel, because enamel gives you always the best bonding. So though deeper the dentine will have to, if it is very deep, the dentine will have to be lined, liner has to be placed. So you can see the older cavity and the newer cavity, or the older concept wherein we have got wide cavities with wider proximal boxes and all. Now it is minimally prepared and there is no need of unnecessary, there is no extension for prevention and all. There is just we have to remove the caries and make sure that bonding is achieved on sound tooth structure, so that we will get peripheral seal. So there are now we need not prepare much, though lasers are coming, hard tissue lasers are also being used nowadays, but then because of its expenses it is not widely accepted as of now, or widely used in this part of the world. So let us hope that day will come when all those laser techniques will come, wherein minimal, what is required only will be removed and rest will be immediately restored with sealed with resin materials, which can just finish off the procedure within no time. So now there is another chair side air abrasion which is used, which are nanoparticles kind of, it is microparticles in fact we have got chair side wherein silicon dioxide or aluminum dioxide particles are under pressure it is fired onto the tooth surface, so that it just removes the surface whatever caries is little left out. So it doesn't also remove unnecessarily dentine. So whatever is required, soft ones only goes off, and then it gives retention to the, especially it gives it works well on the enamel surface, wherein we get proper bonding. It enhances the bonding as well. So roughening of the tooth surface happens. So then that takes us to bonding now next, because bonding between tooth and composite, that is based on this. What we should understand, it is based on two different substrates. We have 2-3 substrates here, like cementum, though not common, enamel and dentine is most common. So that is what we have to understand, how these materials act differently, or how do they act on each substrate. That's how we should understand bonding. So let's first see what is the first step in bonding. As you all know, it is etching procedure, that is the first. 37% phosphoric acid, which is widely accepted, is used for etching, but then there are different techniques in etching which I will be covering. But let us know what are the bonding systems that are available now and which is the modern systems that are in the market. So first, benchmark is the 4th generation. I would like to start with 4th generation because first 2-3 generations are done and dusted with. So fourth generation, though they are considered to be the benchmark one, they had multiple clinical steps of application, multiple application, repeated applications and all, which made the clinical time little cumbersome. Otherwise the bond strength was good enough. Then came the fifth generation, wherein we just acid etch completely. Then we have the primer and adhesive together. So as we know that it contains these three components: acid, primer and adhesive. So first it is acid, which is etching separately to be done. Then primer and adhesive comes in one single bottle in fifth generation. So how the etching techniques differs, I'll be discussing shortly. Then comes the sixth generation, wherein they mixed the acid and primer first, and they had a 2-bottle system. Then they made it to a single bottle, wherein acid, primer and adhesive, everything was mixed together. So that is the present generation. 7th and 8th generations are all acid, primer and adhesive mixed. And so they also they are to be used judiciously, because they have got certain, every company has got a prescribed technique of using. That is very, very important to understand. Never ever use it before reading the instructions given by the company, because every company has got different ways of using it. Some tell you should first take it in applicator tip. Some people tell to dispense it in the well and then agitate it there, then use it inside the mouth, there also again agitate it. So different techniques are there. So we have to read properly and then start using it. So coming to the etching, as I said, I will be explaining about etching procedures: total etch, selective etch, total etch and self etch. These are the three types we have. So selective etch is nothing but selectively etching the enamel, so that, because always etching procedure, it is better to understand that enamel and dentine are two different substrates. So enamel is inorganic, more inorganic. So it is kind of, we can tell it is harder. So what we have to do is we will have to etch it for longer time. So how do we etch for longer time when we do a total etch technique? Because the dentine also gets etched longer time, at the same time enamel also gets. So let us do selective etch first and then go towards the dentine if at all required, if based on which generation. Fifth generation demands you total etch. So what we will do is, if at all you are using fifth generation, then it is better to etch starting from enamel, wait it for 15 seconds and then apply towards the dentine for another 10 to 15 seconds, which should solve your total etch. Otherwise, now the preferred is, even though they claim it to be self etch, it is better to etch enamel, because self etch or any etching incorporated adhesives will have only milder acids. So it is said that it cannot penetrate much into it needs more time to penetrate into the enamel, as because the inorganic content is more. So it is more friendly towards, they have incorporated in such a way that it is more dentine friendly, because dentine, once it is over etched, there will be collapse of collagen and there will be bonding might not take place well. So as we know, that is very, very important. But now there are newer techniques or newer Pascal Magny is a newer author who claims that we will have to apply it and keep it for some time, so that it slowly goes penetrates into the dentine layer and then forms another super dentine structure inside, which enhances the bonding and all. So that is all probably evidence based, though on case based as well. So we will not go into that, but then in general what we have to follow is etch enamel for longer time. So first start with enamel, then go towards the dentine, then it makes finally maybe we will be etching enamel for almost 30 to 40 seconds and 15 to 20 seconds to the on the dentine. Then that should give you a correct or adequate amount of bond strength. That's what I understand. So now bonding agent, we have different generations, as I said, 5th, 6th and 7th. You have you can choose as per your knowledge, your inventories, and affordability and things like that. Case also matters. Some places wherein you think it is very deep enough but better not to etch there, always the choice would be self etching type. So that would be the best choice. And if at all, if you have applied some kind of liner, then you might require selective etching, because that liner material might require little kind of etching so that it will bond well. So it is all based on the clinical scenario that you have to select it finally, but to understand the basics, this is how it is. So just to brief you, that is 3-step, 2-step, 2-step, these are all 4th, 5th and 6th and the 7th generation one. So first one is etching, as I said, applied for 15 seconds, rinse for 15 seconds, primer application applied 1 to 5 layers, see how many times you have to do things. So clinical chairside time is more. Bond agent application, apply 1 layer of adhesive followed by light cure. So in the other case, 2-step, it is easy, etching for 15 seconds followed by rinsing for 15 seconds, then gently air dry. That is very, very important. Means you have to keep moist, because we have got wet bonding and dry bonding. So we as per that is why we should always read what kind of bonding system are we used. So it is all based on the content of that, acetone based, ethanol based, all those systems are there. So we have to read the content, and then accordingly we'll have to. So if they instruct to keep the dentine moist, keep it moist. That is very, very important. And prime and bond, apply 1 to 5 layers, gently air dry. Gently air dry is very, very important. You cannot desiccate the dentine. Desiccate any, because when you sometimes I feel some people, when they air dry, they just blow it off completely. We should do it very gently. Then 2-step bonding in the that is a 6th generation, etch and prime. One application without rinsing, gentle air dry, and then bond, apply on layer, gently air dry, a light cure. But see here it is written as apply 1 layer, but some people tell, if you see the next 7th generation one, etch, prime and bond all together, apply 1 to 5 layers without rinsing, gently air dry, a light cure. So means we have to keep scrubbing on the tooth surface as well. So that is why I tell specifically you have to read the instruction given by the company before doing. So after now covering all the material aspect is done, now the different types of caries is over, the cavity part is over, and now bonding, etching is over, bonding is over. Now the main part is the matricing. So matricing is very, very important in any posterior restorations, as we all know, because the contact has to be, that is the ultimate thing, because every patient comes to us telling that there is food lodgement. They don't tell basically they have a cavity there. Food lodgement is their primary issue. How to solve this is by recreating the contour and contact. So for that, this is very, very important. We should have the ideal way of matricing it, and we should know the ideal way of matricing it. So you can just see the picture of the conventional matricing system, wherein we use the Toffelmeyer, and you can see the modern, wherein like we can call it is in general as sectional matrix system, so which is widely used now. We have got different companies providing that. The conventional system is, the problem is that you can see band displaces the tooth, matrix has flat contour, double thickness of band makes contact harder to achieve, wedge separators. See, when we used to have amalgam, this was okay, because amalgam has got, when you condense, it has got this tendency of going and pushing the material or the band, and you can always it gets adapted towards the wall very well, because it's the kind of malleability property that had, we could condense it well. So that is lacking here in composite, because here layers are placed and then flowable materials are all placed. So there is nothing like it is going to compress the wall and push the wall and all. So remember that in place. So all that we have to achieve is now with the separation what we have to achieve initially, so that a physiological tooth movement takes place and a separation is happening in between, and then the wedge and the matrix is placed in between. That's the reason that ring separators are, or G rings, some people, company people call it as, they are provided along with the sectional matrix system. Palodent V4 is the latest which is widely used, Polydentia, so many companies have got that, but they are one among the most popular, which has got very good clinical acceptance as well. So here if you see, there is no tooth displacement for tighter contacts, and contoured matrix bands for natural anatomy is there, because pre-contoured bands are available. Wedge is contour for better adaptation. Here the wedge is like anatomical wedges, we can call it, like they just go inside and then flex and take up the shape of that particular embrasure area, and nicely adapts well. It also adapts, not only adapts the matrix band sectional matrix towards the tooth. At the same time, it also adapts it well towards the gingival area, and the coal area, everything is preserved as it is. That's the beauty of it. So hollow underside allows second wedge for reliable seal. Sometimes when we have to use double wedging technique and all, we can use another, because the hollowness allows you to keep another thing. These are all very innovative techniques which is widely used nowadays. And ring separators is a must. Please remember to use ring separators while using the sectional matrix. That is very important. See this, this isolated tooth, the band is placed sectional matrix, but that was not giving the correct separation. So when you keep the wedge is not giving the separate. You can see the marginal adaptation at the gingival seat area is not proper. So what at the same time, when you use the anatomy, the wedges given by B4 systems and all, you see how closely it adapts, and see how the gingival seat margin is well closed. So that is very important. Then we get very good contoured restorations. These are all certain. When there is wide contact also, we can see the proximal clear matrix systems which are widely used. That is BioClear system is one of the systems that is widely used for such restorations. They are also very common when we use something called injection mold technique, widely used in that technique. Then we have strong, these are the advantages, that they have strong internal, the wedges which we use, strong internal spine creates tooth separation, collapsing tip for easy placement. You can see how nicely there is a comparison of that conventional wedge and this modern wedge, no gap at all. And those are fender wedges which are available. They are wedge guards. They allow you to not only protect the adjacent tooth, but also sometimes when we do deep margin elevation, it gives us a clinical, clinically well, it adapts so well that we'll get a very good clinical result. That's the reason we go for such wedges. Then comes, this is another system wherein you can see how 270-degree seal it is given. When you keep this with the separator and wedging it properly, anchoring it well, you see how nicely it adapts to the proximal aspect and how well contoured restoration we can get. So now, understanding the proximal contact build-up and all, we should understand the material during placement also, what is the care that we have to, because next is the placement technique. So just before placing it, remember that there is something called C factor, which is the ratio of bonded to unbonded surface of the tooth. Like that is when you place the restoration. You all know that the material is placed inside. So there is a tooth surface, at the same time there is a material. So the ratio between bonded and unbonded surface will give you the correct picture of C factor. So that has to be kept in mind, because always when you cure, the shrinkage is towards the light. So what happens when you can see this picture giving you, when you keep it completely like this, bonding two walls at a time, and then you start curing it, it shrinks, it pulls the wall. So there is flexor action on the tooth surface. That is very dangerous, because that can cause either post-op sensitivity because of kind of pulling away of this material, or if the bond strength is good enough, it might even go into slight crack formation on the weaker tooth structure. So then it can result in recurrent caries, failure of interfacial bonding, then fracture of restoration and tooth as well. So we should always understand what is it, and we should take care to reduce this C factor. So how to reduce it? Altering composite formulations, incremental layering techniques, light curing procedures can be deferred, like multiple can be used from all the sides. Then stress absorbing layers with non-elastic modulus, maybe giving some liners in one walls, and that's how we can reduce it. Then incorporation of macro fillers to reduce overall volume, and preheating composite, where something I told us, the injection mold technique. Then this is the picture of how roughly it gives how the shrinkage happens towards. So how you can connect two walls to reduce that. You can see how the stress is reduced then. So that arrow indicates the stress factor shrinkage, polymerization shrinkage that happens. So that is very important to understand. Now this is something to explain, because everybody talks about all this restoration, placement, everything, but nobody talks about how important is our light cure unit as well. The light cure unit, maybe it might give you the light, but see the intensity. See, this is just an example which I thought I'll just tell, because always we should check your available light cure unit to whether it is giving the maximum output or not. It might give you the light, but light spectrum, say, it can vary from 400 to 600 nanometer. That spectrum, visible spectrum, if it is there, fine, we can get, it can initiate polymerization. But the depth of cure, that is very, very important. It should go inside the lumen, or when the lux or the lumen which is coming out penetrates inside, only then that conversion happens, monomer to polymer. That is based on that is when that is where we should understand the intensity of the light is very, very important. So keep checking your light cure unit to make sure that you get somewhere between that 900 to 1000 1200, that range. Otherwise that is only light emitting, but it is not curing your composite restorations properly. So coming to, after understanding these things, now let us see how placement technique can be done. We have in two techniques, that is, one is with the instrument, and the other one is injecting. So we have certain syringes available which is injected. So ampules we can with guns, these are all available in the market. So whichever is comfortable, but ampule with guns are seriously a good choice when it comes to bulk buildup, say when the base dentine is done, all those things, when it is a very huge restoration. Otherwise maybe instrument would be the right technique to use. Then even more bulkier, then we can go for injection mold technique. That is good way, preheating the composite and directly making it into, again you will have to keep it inside the there is a separate injecting device, or guns are provided wherein it can be put into the ampules and then injected to the cavity. So this can be used. So placement techniques are horizontal technique, three-side technique, oblique technique, vertical layering technique, successive cusp buildup technique, and bulk technique. So this is basically how the picture goes. That horizontal, the first one, then the three-side technique, then oblique technique. See, if you see, one picture gives you that there is a wedge placed, which is clear wedge, which is transmitting light, and light is cured from all the sides. This can reduce the polymerization shrinkage, and to reduce polymerization shrinkage, there are so many other techniques as well. Now we have soft starts curing, light cure units, so many things have come into market. So anything can be used, but these are all the techniques, but keep in mind that this factor has to be considered seriously. Then we can also have different layering techniques like monochromatic, bichromatic, and polychromatic, wherein we use multiple layers. Say dentine can be one shade, enamel can be one shade, because the underneath lining can be opaque layer, then over top up can be a clear shade or giving it more aesthetic look. Then one of the widely used, because clinically what we require is less chair side time, because any patient coming to us is looking at the procedure to be done in a faster way. So what another technique that we have developed is a centripetal build-up technique, wherein any class 2 cavities is just converted to a basic class 1, and then we start building it up. This is bichromatic technique. Bichromatic technique is wherein you give you can see the cross-sectional diagram shown there, wherein cavity, you can see one layer of dentine is placed. So if you see, the dentine is separately two layers, because this is again to reduce the C factor, and finally to give the aesthetic looks as well, because the grooves are incorporated inside, so that it will give you the best of aesthetics finally, as if it looks like a natural tooth later. So this is an stylo Italiano concepts, wherein a Modi cavity is converted to first into a class 1. Both the walls are created, then the dentine layer inside is recreated, on top enamel layer is made with clear. You can see how well the secondary features are incorporated, and it looks ditto like a natural tooth. This is bulk fill technique wherein you don't have time. Certain people are not very skilled. Such people, what you can do is you can just build one dentine bulk layer inside and on top enamel bulk layer and roughly contour it and then use your instruments. So trimming instruments to make the shape and then give the final finish. So this might be a good option for post endo restorations and all for the time being and all. But then later, if it is for a long term, then I would prefer you to go for the centripetal and then the selective cusp build-up techniques. That will give you better aesthetics. Then this is the most important things I would tell, because after layering and building up everything, what we have to make sure is the contour contact includes also the occlusal contact, so to the opposing tooth. That is very important. Occlusion has to be checked. It has to be articulated very well to check for the occlusion and make sure that it is very much within, because otherwise it can fail where high points are there and it should be within the it cannot be in that functional cusp areas where the margins cannot be left in that areas, because it can cause stress, concentrations can be there and failure of restoration can happen. So we should always have that 100 microns and 40 microns the Bosch and the 40 micron articulating papers that has to be used. There are different 20 microns ones are there. So we have to check if the articulation is proper with proper centric occlusion and all occlusal movements, and then make sure that high points are completely removed. Then coming to the finishing and polishing, generally people do a nice contouring and all, and finally when they finish it looks like this. So let us see, keep in mind that it has to be done in the proper or scientific way. So first, after, try to do all your cusp build-ups, everything with cusp build-up and all initially itself, and check for the occlusion, and then start doing the fine finishing after that. So after articulating initial articulation and all, then you can start polishing it. While polishing, you can use initial finishing burrs, as we all know. It can start with the red banded with the gross finishing, and then we'll go to the yellow banded ones which are super fine, and then go towards the fill tips. Or now there are zirconia fill tips which are available widely. Though posterior, I would recommend you to use spirals, because spirals are the best for the finishing. We have got different brands giving us that very good finishing. Even Ivoclar company has got, even Dentsply is giving us spirals. I mean 3M company is also giving us spirals. So we can use these final finishing with the spirals. That would give you a better, or fill tips like this zirconia incorporated tips. Then proximal polishing strips are to be used, because that contact areas has to be nicely contoured, and make sure that there is no food lodgement. At the same time, there should be enough freeway that is it should be flossable. So that is very important. So make sure that your floss passes, and then final finishing can be brought in by certain buff and other brushes, goat hair brushes, pogo polishers, enhanced systems. So many polishers are available in the market. These are few. And finally, we can also use buffing. So this is just to show you how the final restoration, all sequence. Remember about the caries I told you, then the caries removal, then the cavity preparation, then comes how the the proximal aspect has to be. Remember, we are only removing caries. We are not extending the cavity unnecessarily at all. See how nicely isolation has to be done and wedging has to be done. Proximal contour matrices has to be kept, and then we have to build it up wall by wall. So that is when we will get the final restoration beautifully, and check for occlusion and make sure that everything is, so we are giving a proper functional tooth. That is what our aim should be. So to conclude, it's important to understand how a tooth functions in normal occlusion, how one should mimic it in posterior composite restoration. That is what I wanted to convey through this presentation. Hope I have done my best, and thank you all for listening. Thank you once again.